as far as post-surgical complications of presenting with sexual dysfunctions are concerned, most commonly these complications are found in after colorectal surgeries, more often for malignancy than for benign surgeries. With recent advances in cancer management, with increased survival of patients, and quality of life and sexual functions are becoming important. In malignant patients, after surgery, it is found to be as high as 60 to 80% of the patients. Still, it is under-recognized and under-reported in India. It affects both men and women equally. Erectile dysfunction is the commonest dysfunction in men, and vaginal dryness is commonest in women after surgeries. Then one should think why these sexual dysfunctions are common after surgeries. The etiology is multifactorial. Most common etiology is penile pelvic nerve injuries, and other causes are psychological, like presence of stoma. If surgery is done for malignancy, it is the complications are more common than for benign surgery. Benign diseases like inflammatory bowel disease or surgeries done for colonic or rectal polyps. Age, these complications are found more common in older age groups, specifically if their sexual dysfunctions are found pre-operatively, then they can increase post-operatively as well. It depends on tumor stage as well. Higher the tumor stage, more are the complications. And if patient is received neoadjuvant radiotherapy or patient receives post-operative radiotherapy, then the sexual dysfunctions are more common. Radiotherapy causes damage to penile vessels as well as atrophy of vagina and fibrosis of vagina, which leads to sexual dysfunction. This is the anatomy of pelvic nerves. Parasympathetic and sympathetic nerve fibers, they form superior hypogastric plexus at the level of inferior mesenteric vessels. And these plexus are very close to the rectum. Though God has given protection for this plexus by providing Walden's fascia behind the rectum and denominus fascia in front of the rectum, still some surgeons manage to injure them during surgery. As we know that the sympathetic fibers, they supply to the smooth muscles of ejaculatory ducts and seminiferous tubules, which is responsible for ejaculation, and parasympathetic fibers, they are responsible for vasodilatation and erection of the penis. At what level of surgery injury can happen is also important. Actually, superior hypogastric plexus can be injured at the time of ligation of inferior rectal pedicle, as well as during dissection of in the presacral area. And damage to sympathetic nerve fibers can cause ejaculatory dysfunctions. And parasympathetic fibers can also get damaged if during surgery dissection goes too lateral into the side wall of the pelvis or goes too anterior beyond the fascia of denominus. Apart from hypogastric plexus, pudendal nerve is also likely to get injured during surgery. Pudendal nerve at the level of proximal and mid rectum is safe, lying in the pudendal canal. But at the level of lower rectum, the nerve gives branches, terminal branches like deep perineal nerve and the nerve to the dorsal nerve of penis and clitoris and inferior rectal nerves. These deep terminal branches of pudendal nerve get injured during abdominoperineal resection. That is required for malignancy of terminal rectum or anal canal. So, pudendal nerve is not damaged during anterior resection done for proximal or mid rectal surgeries, but get usually damaged for during surgeries for low rectal malignancies. So what sexual dysfunctions are common in post-operative period? In men, erectile dysfunctions, ejaculatory dysfunctions, orgasmic dysfunctions and loss of libido. Actually, loss of libido is common in both. Erectile dysfunctions and ejaculatory dysfunctions are common in distal rectal surgeries, while orgasmic dysfunctions and loss of libido is common in both proximal and distal rectal surgeries. In women, dyspareunia it occurs more after distal rectal surgeries, while vaginal dryness is common after both. In women particularly, in addition to nerve injuries, there is post-operative fibrosis, and it is more in case of patient if she has received pre-operative radiotherapy, and this fibrosis can cause decreased vaginal pliability, and which result in dyspareunia. So, what are the risk factors of sexual dysfunction patient undergoing surgery? First is nerve damage, then surgical extent. It is found that surgeries done for colon malignancies or colonic pathologies, they are less likely to cause sexual dysfunctions than the rectum. And in the rectum itself, surgeries done for rectal surgeries are more common, dysfunctions are more common in that. As far as surgical technique is concerned, the complications are different in open, laparoscopic and robotic. We will see it in next slides. It depends on surgical expertise. Experienced surgeon, in the hand of experienced surgeons, nerve injuries are less common. And dysfunctions are directly proportional to the blood loss, anatomical leak, and the presence of stoma. Stoma is also an important topic. We will cover it in the later part. As far as open and laparoscopic surgeries are concerned, initially in the first decade of this century, it was found that open surgeries are better than the laparoscopic surgeries because laparoscopic surgeries were upcoming and surgeons were getting to used to it. But in the second decade, the studies show that laparoscopic surgery is far better and dysfunctions are less in surgeries done with laparoscopically. Laparoscopy can give proper visualization of nerves which lie deep into the pelvis, but surgery itself requires higher skills, without which nerve damage can be significant. Robotic surgeries is nowadays very well preferred for rectal surgery, and it is found to be the nerve injuries are found to be very less than that of laparoscopic surgeries as well. Then after nerve injuries, we will come to stoma. Stoma is nothing but the artificial opening made in the anterior abdominal wall through which urine and stools are exteriorized. The stoma can be temporary or permanent. Temporary stoma is done for malignancies in the proximal rectum, and distal rectum, the stoma is usually permanent. It is unlike nerve injuries, sexual dysfunctions are common for surgeries in which stoma is done for whether the etiology is benign or malignant. Impact of stoma in sexual dysfunction is tremendous. It is found in the literature that among half of the couples which are sexually active remain sexually inactive after surgeries in which either of the partner has stoma. It is because the patient himself made perception about himself that he feels less attractive sexually. His self-esteem gets lowered because presence of bag and lack of control over passing gas and stools with associated unpleasant smell and sound. The patient develops negative body image about himself, and also relatives surrounding, they found it difficult to look at the patient having stoma. So these patients are less likely to seek out partners for sexual intercourse. So in anticipation of these complications, clinicians should talk with the patient and the partner pre-operatively that such things will happen, and If stoma is permanent, then the sexual dysfunctions can be more common than the temporary. Even after reversal of stoma in temporary, the sexual dysfunctions they recover but not recover fully. During research, I found that an observation which I like to mention here, that couples where female partner has stoma are less sexually active than those in which male partner has stoma. So, whenever patient has stoma post-operatively, it is our clinician's duty so as to get patient and the partner adapted to the situation as early as possible. We should ask patient to take care of the stoma itself, herself or himself, because if initially post-operative period partner is used, patient is usually dependent on partner for taking care of stoma, and in that case the patient looks towards partner as friend or caretaker rather than sexual partner, and sexual partner also thinks about the patient with sympathy rather than love. So we can ask patient to empty the stoma bag before intimacy so as to reduce the fear and leakage and bad smell. We can reassure the patient and partner that physical contact during intercourse will not harm the stoma or loosen the pouch. Early adoption to reduce anxiety and improve the quality of life is essential. So how to evaluate sexual dysfunctions in post-operative patient? Clinician should start the conversation because patient may be reluctant to ask, and your question should be, your first question should start in such a way that dysfunctions are common in post-operative period. Are you facing any? After that, patient may open up. There are various validated questionnaires available which can be used for evaluation, and once it is confirmed that patient is facing sexual dysfunction, we can refer the couple to sexual healthcare expert for further management. This is a PLEASE model which can be which is crucial in the post-operative period. That is permission to discuss about the sexual function in the post-operative period. We can give limited information about the complication. We can give specific suggestions so as to adapt to the situation well, and intensive therapy. Treatment, I am not the expert in the treatment, and as you are all very expert in the field, but last sentence is important. Patient has right to choose the best treatment. Take home message is sexual dysfunctions are common after colorectal surgeries. It is common in both men and women. Still the issue is inadequately addressed preoperatively. The role of partner in this is important, and early evaluation and timely treatment is required to improve the quality of life in such patients. Thank you.